to do a little introduction for
Okay.
everybody here
Okay.
about sort of who we are and what we're doing here. And hopefully that will be great. So welcome everybody to GOWME, the Global Organization for Wilderness Medicine Education. My name is Valentina. I'm a soon-to-be fourth-year medical student, but still a third year. Finished my clerkships though. I'll be applying to emergency medicine residency this fall, and I am one of the co-vice coordinators for GOWME this year. So this is our educational lecture series that happens sort of bi-monthly. So this is our mission about what we're doing and why we're here and why this started. It was started originally by one founding member, whose name is Shilpi, who's still kind of advising from the background, who basically saw a deficit in the area of wilderness medicine education in medicine and said, let's fill it. So our idea is that we want to create an educational platform that we can really hone into the ideas of wilderness medicine and emergency medicine and other components that sort of go along with those things, and to help us create a diverse world for people who are interested in this thing, and everybody's sort of coming at it from a different perspective. And so using healthcare and medicine to interact with the wilderness medicine and our often hobbies of being outside. So that's who we are. You can, read there. Um, this is our mailing list. We love whoever is here or spread the word to join. This is how we sort of help people stay updated about what's going on, opportunities that are available. We're having a fellowship showcase next month about wilderness medicine fellowships, all kinds of great things. So please join our mailing list. These are our internet accessible options. You can watch previous lectures that happened on YouTube. We also post a bunch of things on Instagram where you can see what's coming up or other available things too. So follow us wherever you can. We'd love to have more people. These are what has happened. We're kind of at the end of our semester here, so you can see. And so but our next last sort of wrap up for the spring is just our fellowship showcase. So we'll have a bunch of people talking about wilderness medicine fellowships. We're doing a gear giveaway. So I'm going to drop into the chat here in a minute the Google form to enter the gear giveaway. These are some of the items we're giving away, as well as to sign up for our mailing list. So you can find those in the chat. It's obviously free to enter. You just come to these lectures and you sign your name in there and you get entered. This is our board members. You can see here, Shilpi is the founding member, and these are kind of the people who are now running it into the future. You can see me there on the bottom. This is the rest of our team. They're all awesome and make things come together. So now to the real meat of the sandwich here. I'm really excited to introduce Dr. Jessie Stone. This is a bio that we've sort of come up with for you. Please correct us
I'm
if
like,
we're
I've
wrong
never
here.
seen this before. Great.
So Dr. Stone graduated from New York Medical College. From what we are unknown, and she's decided that more than being a doctor, she wanted to be a kayaker, and so she decided to become a full-time kayaker. And then she went on a trip to Uganda, where they basically brought her back to medicine a little bit, and you know she couldn't get away from it as much as maybe she tried to. So she came back to medicine by starting a clinic in Uganda that's called the Soft Power Health, that focuses on malaria education and prevention, but it's definitely expanded and inclusive
Yeah,
of
I
more
can
things.
actually I can add a lot to that. It's a primary healthcare clinic, and its focus is primary care because that's the scarcest resource in terms of healthcare needs there. But that said, we do a huge amount of health education and prevention. So we have 6 dedicated outreaches that are for the following: malaria, family planning, malnutrition, domestic violence, physiotherapy, and organic gardening, which is a complement to our nutrition outreach program. So those are things that are going on every single week of the year alongside of the clinic. And the clinic, just to give you an idea of how much need there is for primary health care, health education, and prevention, Last year, we treated 35,000 patients in our outpatient clinic, and we reached another 20,000 patients through the 6 dedicated outreach programs. So, and we're not, a huge fancy operation. We are about 95 in staff, and that includes doctors, nurses, laboratory technicians, physiotherapists, dentists, administrators, drivers, local educators, cooks, cleaners, gardeners, a whole range of people, but all Ugandan, all 100% Ugandan staff. So that's
That's
just
so inspiring.
well, thank you for saying that. It was all through kayaking. So it's which, I still do to this day. I'm a little bit about my kayaking background. I was a dedicated kayak bum, let's say. I taught kayaking for years. I've spent a lot of time competing in kayaking. I've been a member of the US Women's Freestyle Kayak Team 6 times. And so kayaking and medicine always kind of went hand in hand. I ended up doing a lot of expedition medicine as well as a kayaker early on, and that was a lot of fun. But now in my current life, when I'm in Uganda, I'm kayaking and I get to work in the at the clinic and out in the outreaches. So, it's a really nice combination of both.
Well, I mean, if you said nothing more, you've already said so many interesting things to us all this evening. But I'm gonna stop sharing. So hopefully, do you want to share yours, or I haven't, or do you want to share your slides yourself, or would you like me to try and do that for you?
Sure, you can try and do it.
Uh, let's see. I will need you to send. I don't. Let me see. Let me. Didn't get. Did you send them to someplace in particular?
I didn't send them. So tell me what the best way forward is. And because I think what I understood is that like on the thing below, there should be a place to share.
Yep.
And
You
I'm just
just, there should be
looking
something that
for it
says
under.
share screen down along the bottom there.
Okay. I'm just looking for the share screen. Okay. There we go. Perfect. Okay, there it is. Now we're in business.
Amazing. Perfect.
Okay. Can you see it?
Yes, we can see.
Okay, great. I'm going to go to play. All right. So here we are. Our topic tonight, which is definitely related to, let's say, adventure travel and developing world medicine, is schistosomiasis, otherwise known as bilharzia. Dr. Bilharz was the doctor who originally discovered this parasitic infection many years ago. And it is something that we see in our setting incredibly frequently. It is very, very common. And it is known as a neglected tropical disease because it tends to infect a population of people who live in the developing world who, most people, if you ask them who are not in medicine, have you heard of schistosomiasis? People have never heard of this disease. So it falls in the category of neglected tropical disease. It is caused by a trematode fluke of the genus Schistosoma. It has a much wider impact than people know. I mean, the estimate is 280 million people worldwide infected with schistosomiasis, but I suspect it's more than that. And especially one of the things that we've experienced in our clinic, we are very close to Lake Victoria and the source of the Nile. And the Nile, as I'll get to further, in this talk, you'll see more about this too, has been dammed repeatedly. And this has created large pools and portions of standing water reservoirs. And this has also allowed the water and people to have more access to the water, which on the one hand, maybe that sounds good, but it has a real negative downside. And we'll get to that. So anyway, I think many more people are infected. There are many more mega hydro dams that are being constructed all over Africa, even as we speak, which is really a shame. Um, that's a whole other, we could do another talk on the downside, the public health downside of mega hydro dams, but I'll try not to talk too much about that in this talk. So in sub-Saharan Africa, there are approximately 280,000 deaths per year because of schistosomiasis. And 90% of people that require treatment for schistosomiasis live in Africa. So schistosomiasis is a disease of the developing world, principally. The only exception is in Corsica. There have been, in 2014, cases of schistosomiasis were recorded from people who were swimming and bathing in the river Cavu. So keep that in mind if you're headed to Corsica to do any kayaking or anything else. As you can imagine, poverty combined with limited access to clean water, poor sanitation, hygiene, increase the likelihood of the disease. Sorry, I'm having let me go back. So can people see there's like a big black line on the top here, and I'm just wondering if I can get rid of it because it, at least from on my slides, it's cutting off the top of the type. So I don't
We can
know.
see the whole slide.
Okay. Okay, good. So basically, there are approximately 4 million Ugandans infected with schistosomiasis at this time, give or take. The population is 46 million in Uganda, and more than half the population, 55%, are at risk of being infected because so many people have access and need access to fresh water for all their activities of daily living. So it's a big public health problem. And Lake Victoria, which is the source of the Nile and the second largest body of fresh water in the world, is the largest source of schistosomiasis. And, that is, so you have Lake Victoria, you have the Nile that flows out, and then Uganda is populated by a number of other lakes and other branches of the Nile as it flows north to the Sudan. And all of those areas are infected with schistosomiasis. So, it's everywhere, basically. It's everywhere where there's fresh water. And as I mentioned before, mega hydrodams have increased the prevalence of this disease significantly. So this is a picture of the latest mega hydro dam that was built on the Nile, and it's called Isimba Dam. And it has created one of the largest reservoirs of any mega hydro dam that's been built in Africa. And it has displaced thousands and thousands of people. And as well, it has created this it's not actually not moving, but it's effectively like a big lake. And so one of the things that is well known is displaced people from dams, especially in developing countries, their quality of life goes down. It does not go up. And we have certainly seen this in our population of patients. Like the patients we serve were directly impacted by the construction of this dam. And, there were many knock-on effects, but one of them was the fact that schistosomiasis jumped up dramatically in the years since this dam was constructed. So other reasons, why these dams can help increase the rates of schistosomiasis, is the large standing water reservoirs where before the river was much more difficult to access, and you had, people who were not all squeezed together into different places where they have now since their homes and areas they lived were completely flooded, they had to move, and they had to move often to places that were already very heavily populated or more populated. So you have more people, you have more water, you have slower moving water, you have access for all the activities of daily living, which is water collection, washing, bathing, swimming, fishing, sand mining. So there's a lot of economic activity that is also derived from the river. Most of the population we work with are fishermen or subsistence farmers, and the subsistence farmers are often, if they can't rely on regular rainfall, they are also going to the river to collect water, not only for their cooking needs or their washing needs or whatever, but also for watering their garden as well. So there's constant exposure to water and to schistosomiasis. So areas of displacement, in areas of displacement, conditions, these conditions lead to increased poverty, and this has definitely been observed in our patient population and has led to more disease. Interestingly as well, the rise in adventure tourism, and in particular, what we've observed in Uganda, so that's rafting, kayaking, tubing on the Nile, stand-up paddleboarding, whatever it may be, has also led to increased rates of schistosomiasis in visitors. So there's been a big jump in that as well. So this is an example of, this is one of our patients, and she's cultivating her garden, and you can see ready access to the Nile right there. These are fishermen. So, walking in and out of the river. This is daily activity for them. These are sand miners. So they're actually diving down to the bottom of the river, scooping up sand and, dumping it into their boat and bringing it to shore, and then it's taken away and they sell the sand. And this is, ongoing activity, every day. And here's somebody bathing. So, this gives you an idea of how much contact, average regular contact people have with the water. And then you have kayaking or rafting or whatever the case may be, as another way that people are exposed. There are two major types of schistosomiasis. There's intestinal and urogenital schistosomiasis, and 6 different species. And what we see in Uganda predominantly is Mansonia, Schistosoma mansonia, and it causes intestinal schistosomiasis. Interestingly, the only species that causes the urogenital schistosomiasis is hematobium. But if you look at, where, at least on this slide, where, the disease is found, it is very often and predominantly in the developing world, in and around the developing world. And again, the heaviest burden being in Africa. So this is what a mature Schistosoma mansonia worm looks like. Not that we would ever see one up close and personal, but just to give you a good idea. And again, here's a fisherman at work in the Nile. And to emphasize the point that the people who are mostly impacted by this disease, are poor and displaced communities, and particularly, fishing and agricultural communities. That's what they're doing for their bread and butter, for their survival. So how does transmission occur? Like how are we getting this? How does it work? So because it's a parasitic infection, it requires us, and in this case, snails, to be intermediate hosts to complete the life cycle. So people are infected initially when they're in the water, and the cercariae penetrate the skin. Now, this is not something you're going to feel or notice at all. The cercariae migrate to the portal venous system, and then there they mature into adult worms. And then once they've matured into adult worms, then they can mate and lay eggs, which end up in the venous system of the bowels, and if it happens to be hematobium, the venous plexus and the bladder. There, adult worms will lay eggs that are shed in feces and in urine. So then this is what starts to begin the cycle. Again, the eggs hatch once they're in the water and they release miracidia, which is another phase of the life cycle, which infects the susceptible snails. It's important to note that not all snails are the hosts of the schistosoma. They're very specific snails, and I have another slide to show you on that. But then the cercariae emerge from the snail, and then that's the infection point. So then that is the infective stage when they're the cercaria coming out of the snail. Other sequelae from the infection, eggs can get trapped in organs and tissues and cause immune reactions, granulomas, damage to organs, fibrosis, all these things. In addition to just having the immune response that develops to where the eggs are and the adult worms are in the body. So again, besides local populations, ecotourism has seen a rise in schistosomiasis in visitors, and urogenital schistosomiasis increases your risk of HIV infection, especially in women. Okay, here's a little graphic of the infection cycle just to give you an idea. So there are, again, different types of schistosomiasis. They inhabit different kinds of snails, but the life cycle is the same. And it's basically the fecal and urine deposition in the water that then reinfects snail, that reinfects the human, and then that continues. So that's where you can see that good sanitation, hygiene, clean water would make a huge difference for people. Okay, so our snails, here they are. 3 different kinds of snails here to show you what they're distinct snails for the different kinds. The one in the middle is the snail that is the host for Schistosoma mannsoni, and mannsoni is the predominant type of schistosomiasis that we see in Uganda. So again, symptoms of schistosomiasis. I mean, one thing to consider, there are the early symptoms, which we don't see, do not come to the clinic. We see people with very advanced disease most of the time. And if we have a history, and sometimes when someone comes in and we suspect that it might be schistosomiasis, we'll test them for it, even though that may not be their chief complaint. But typically we see people with very advanced disease. Otherwise, in someone who, let's say, has been a traveler, a visitor, the early symptoms that you would see are, number one, fatigue, diarrhea, undulating fevers. You may have abdominal pain, and you may have blood in stool. In 10% of cases, you have something called Katayama fever, which can develop very soon after exposure, like within 10 days to 2 weeks. And that's presents as a high fever, usually an itchy skin rash. And, and at that point, if you did a urine test, you would probably get a positive test. But at that stage of the life cycle, the schistosoma hasn't necessarily made it to being excreted in feces yet. So that's a little bit longer down the road. I mean, schistosomiasis takes several months to really progress till it's symptomatic. Usually people become symptomatic maybe 4 to 6 months after exposure. It's not right away. So it is kind of a long, slow, painful process to develop this disease. So in advanced cases, what you do see is abdominal ascites, hypertension of the abdominal blood vessels, splenic enlargement. That's all extremely common. In urogenital schistosomiasis, you can see blood in the urine, kidney damage, bladder and ureter fibrosis in advanced cases. For women, you can have genital lesions, vaginal bleeding, pain on intercourse, nodules in the vulva. And, for men, pathology of seminal vesicles, prostate, and ultimately in both men and women, if that's untreated, it can lead to infertility. And as mentioned earlier, disability occurs long before death. And this really impacts people in the population we see in their inability to continue working or leading any kind of a normal life. And so the sooner that they can get treated, the better. And, many people make a very good recovery, and in some cases, a complete recovery, but the treatment course is long. In children, so it does impact children a lot who live near water bodies. Early infection causes anemia, stunting, and malnutrition. And again, impairment of organ function can happen like with the liver, the kidney, and if untreated, it's a very painful, really unpleasant way to go. And these patients suffer a lot. Certainly, in my estimation, deaths due to schistosomiasis are vastly underestimated. Like if you go look at the data that the WHO has or the CDC, I think it's vastly underestimated. This is one of our patients who was 14 years old when he came to see us. His sister had died of the same mysterious illness because the family knew nothing about schistosomiasis when they came to see us. We started him on treatment, and he's doing really, really well. He's almost made a full recovery at this point. But this is how most of our patients present. This is usually how far advanced the disease is. And, in his case, you can see the obvious ascites and the malnutrition. He couldn't bend over and tie his shoes. He couldn't go to school. He could barely walk. He couldn't breathe. He couldn't lie down because he couldn't breathe. So, this was really tough. And I suspect he wouldn't have made it if he had come much later to see us. And he lives 4 hours away from our clinic. So he has made the journey to see us 4 hours each way for the last 2 years, and it's made a huge difference, which is wonderful for him. So we've had a patient population, children and adults, in this condition. And the interesting thing to note is that most people don't know anything about the disease. They have no education about it. So they don't understand it comes from the water. They don't understand, what causes it. So the way that we make our diagnoses, if a patient presents like that and they're in that age group, it is almost, if they have any history of water contact, then that's, a diagnosis by like exclusion, because it's pretty obvious. The typical ways to diagnose it in our setting are to look for eggs in this stool and using a urine rapid test. So the urine rapid test turns out to be more reliable than the eggs and stool, because that eggs and stool, you may get a sample and there may not be a huge amount of eggs and stool. You may miss that. So it may not happen, but the urine test is very good, very sensitive and specific. And again, children who have hematobium will have blood in the urine, and that can be picked up, quite easily. The downside to the rapid test for Manson eye is that it's very expensive, and we have to import it from South Africa. So we don't always have it. We have it as much as we can afford to have it. Another, sign that we look for in that setting is elevated eosinophils, because they will always be elevated with a schistosomiasis infection and with really most parasitic infections. So what do we do about this? How can we tackle this huge problem and help people have healthier, better quality lives? And, you know, the critical thing is education, teaching them about the disease, making sure that families are educated about it. And I think prevention is very tough in certain circumstances, like the boy you saw before. It's easier to tell him don't go in the water because he's a kid playing in the water with his friends or whatever. But if there's an adult fisherman whose livelihood depends on fishing, he's not going to change his profession. So what we have to do is help educate him about it, how it's transmitted, and then also help to treat and to control. So there have been two tactics that the government of Uganda has embarked on. One of them has been treatment, one of them has been control. And so control has involved trying to limit the spread of disease without curing the problem. And the best treatment for both control and curative treatment is praziquantel. And it is pretty well available and it's very cheap, which is good, but supplies of that do run out from time to time, and they often don't make it to the last mile communities who may really need them. Like the community where the boy in the slide comes from had we think we treated at least 10 people from that community, and they all helped educate each other. They are quite far from where we are. So despite the fact that we do a lot of outreach, that's farther afield than we would go to do outreach work. That said, we do a lot of local education about the disease and try to help people to, have the tools to make better decisions about what they do in and around water. And that if they are in contact with water, that they need to come get treated at least twice a year with praziquantel. So ultimately, the answer to this problem is improving sanitation, hygiene, and clean water access. Some programs have tried snail control, but I don't know of any that have been really successful with that. One word about the snails that do, that do host the Mansoni are that one snail can infect a radius of 3 kilometers. So it really can be like one bad infected snail can cause a huge problem. The issue is, there isn't really a program that is targeting snails. Is that really realistic? Where's the money to do that? All these questions come into play if you're trying to talk to the Ministry of Health about how to work on a neglected tropical disease like schistosomiasis, because it's also not the only one. So, so right now, the best thing to do is education and to help people understand what the medicine is they need to take and how they can limit their exposure or take treatment at the same time. So here's Kyria, our patient, about a year and a half into his treatment, and he's really doing so much better. At this point, his ascites is markedly decreased. He's feeling much more energetic. He's gained weight in all the right places. He can play outside, go to school. He can really resume his life the way it was. So he's making an amazing improvement, and we're really happy to see that. And again, if we can treat people for the length of time that's needed, and they have advanced disease, they do recover. So that's very good news. So all of this, treating all these patients with advanced disease really led us to say, hey, what's going on locally? Like, since we can't get up-to-date information about the prevalence of this disease in our area, we really don't know. Let's try to figure it out, starting with our home village. So we work with the Global Health Program at Mount Sinai in New York, and have done for a long time. And with their MPH students the last 2 years, we did surveys both in our home village and in the neighboring village, which is one village away from the Nile. And we discovered that in our home village, there was a prevalence rate of 52%, which was pretty shocking. And then also equally as shocking, at least to me, was the fact that the village away from, one large village away from the river, the prevalence rate was 35%. And so we've been working with the district medical office on trying to do a control campaign of mass drug administration. And so we're making steps to get that accomplished. Our limiting factor, of course, is having enough praziquantel to do that, and working with the Ministry of Health so that we ourselves don't have to foot the bill, that we can share that with them, because that becomes really expensive and unsustainable for us to do. But in the process of doing these studies, we're able to really educate people about how the disease is transmitted, how they can protect themselves. If they have any questions, they can always come to the clinic. If they want to be tested, they can always come to us. And just helping people really understand. So that, has been a very positive step in the direction of trying to deal with this disease. And here's one of our MPH students interviewing one of their village families at home. They're fishermen, so to find out about, what they know about the disease, and if they'd been treated, all of that kind of thing. And then the student Sakshi presented this really nice paper, which was kind of a summation of everything that was discovered in the course of the survey in our village. And I think the main take home is that in these, especially a disease like schistosomiasis, which is a neglected tropical disease, not that much is actually known about it on the ground in the countries where it has the most impact. There's a lot of estimation going on, and we discovered that in our own, surveys. A lot can be done to combat this disease with education and helping people understand how to prevent it, how to treat it, but also, on the public health side too, improved conditions of, clean water, sanitation, hygiene, these conditions of poverty, which are so prevalent. Also improving those conditions and would make a world of difference for people. So happy to answer any questions. And thank you for your interest in schistosomiasis. If any of you are traveling to the developing world and you're going to be in any kind of freshwater body, make sure that if there's any schistosomiasis where you're going. If you have any doubts, you can certainly, when you get back, you can find a rapid test. I don't recommend the blood test here for schistosomiasis, but the rapid test should be available, and it is quite sensitive and specific and good. So any questions or any thoughts? Happy to hear them. One last thing I want to add is we like to say at the clinic that, and this is not to sound totally morbid, but malaria, which is another parasitic infection that we see a tremendous amount of, more than schistosomiasis, is kind of it has a rapid onset and rapid death if it's untreated. Schistosomiasis has a long, slow onset and a long, slow death if untreated. So it's kind of opposite ends of the parasitic spectrum that we are seeing.
I'm not sure if you can see the chat or not, so I'll just read some question. There's a question in the
Okay,
chat
sure.
here, and that says, as far as prevention for the case of the fishermen, could you talk about the prevention options again, or is it just a matter of treatment? Is there anything analogous to mosquito nets where they can have a suit
Yeah.
or something that can they can put on when they get into the water?
Yeah, that's a great question. And I wish there was something analogous to a mosquito net for schistosomiasis, but there really isn't at this point. There isn't. Um, it would be a wonderful thing for somebody to work on for sure. It's at this point, the best bet is basically education, explaining transmission, explaining how you get it, how the cycle works, so that people are aware. Um, and and ultimately, look, I'm going to be completely honest. I kayak in the Nile all the time. I treat myself twice a year because I do not want to have schistosomiasis, and I have had active infection before. So that's the same, we try to educate people in the same way. Like, okay, if you're going to make that choice to be in the water, this is what you need to do to be healthy and stay healthy. It's just that the scarcity of resources in terms of the education resources in a setting where you have, like in the US, for example, we have one doctor for 340 people. In Uganda, you have one doctor for 25,000 people. So, the kind of access to both education and treatment is much more scarce for people. So the poorer communities tend to be really left out of that. So those are the ones who need the most kind of intervention and educational help as well. And luckily, at least in our setting, we do reach a lot of those people. So that's good. But sorry, I went off on a tangent. Right now, no prevention is available. It's really just education and then treatment.
We've got another comment that says, thank you for the presentation. Hopefully some advances in a potential vaccine, such as a Tay SMP80 research may have some fruition. I'm not sure if
No, for
I.
sure. A vaccine would be great. I mean, look, we now have a vaccine to a parasite. We have a malaria vaccine that's really good and effective. Nobody thought that was going to happen. So there is definitely potential for that, and would be so welcome. The like hiccup is that this is a neglected parasitic disease, and we really need someone to think about doing it who doesn't have their eye on, the purse strings, who wants to do this for the good of humanity, really. So that's the catch, really.
I have a question of my own,
Yeah.
sort of a two-part one. The first one is, I guess, my initial belief was misunderstanding was that I thought it was maybe access to care that was the limiting factor, but it really seems like education about care is actually the limiting sort of
It's
factor.
both of those things, I would say, right? So it's like
Okay.
there is limited care for sure, but there's also limited education. If I tell you our clinic is the second largest deliverer of healthcare in Jinja district, which is the second most populated district in Uganda, and we are basically a small-ish outpatient clinic, that's crazy, right? Like that's but that is the reality of healthcare in that setting, you know? So care is a scarce resource. It definitely is. So education and care both are very limited.
The other part of the other question that I have is really, so 2 times a year prophylactic is enough to be treated and live kind of consistently exposed to, but twice a year is enough to
I
be.
mean, yes, because all right, why is it enough? I mean, it's enough because it's working so far, but also, it's because I don't know, like in our area where all the infected snails are, like where I'm in the river, I don't know where all the snails are. I mean, certainly if I'm symptomatic, I'm going to treat myself, but I'm treating myself if I'm asymptomatic also because, you don't know what could happen in the future. There's schistosomiasis has a way of sneaking up on people later on, and you know, the eggs can end up in places that are nasty. They can end up in, your central nervous system. And that's a really bad place for them to end up. So you don't want to, that's not a risk I'm willing to take. So I'm happy to do the treatment. It's very easy to do. And
If someone does end up getting infected, how long does their total treatment really need to be in order to clear that from their system?
okay, excellent question. So basically, if you are symptomatic, and technically, like when we have visitors, volunteers that come and they're in the Nile and they leave Uganda, the prescriptive, like the dosing guidelines for praziquantel are as follows. You want to take the dose of medicine, which is 40 milligrams per kilogram of body weight. Yeah, 10 weeks or more after your last exposure to water. So it's better if you err on the side of being too far along the process, and you have to do that 2 days in a row. So that dose 2 days in a row. And then, okay, assuming you haven't been exposed to water again, infected water, 6 weeks later, you do the same dose again. And that is to ensure that you have cleared the infection from your system.
Wow.
Yeah. Yeah. No, it sounds terrible. It's really not. The worst thing about praziquantel is the way the pills smell. They smell horrendous, but once you get past that, it's okay.
I mean, it also adds to the toll of, especially for like a 14-year-old boy and his family to commute to get that for so long.
Yeah.
It
Yeah.
really adds to that impact,
Yeah. Yeah.
especially the financial impact of his family having to not work for that time to get him to that, the
Yeah.
other implications for sure.
For sure. For sure. But the
Mhm.
good thing is he will be able to lead a normal, productive life, getting through this. That's really good.
Yeah, it's amazing. Does anybody else have any questions, comments, thoughts? Well, I just want to say thank you oh, there are some thoughts here. Is that the same bi-yearly dose? Is the first question. And then
Yes.
the next question is for that patient, could you have prescribed him, um, could you have prescribed it to him and then taken it, and then he takes the prescription home?
Well, because of the condition he was in, we need to measure all the parameters of malnutrition. You know, in the beginning, we were having to tap his abdomen because the ascites was so profound. And then, we really have to monitor him through that process. So at this point, because we want to not lose patients to follow up and not lose him to follow up, we want him to really complete this process. We have him come back, and we try to do that as much as we can for patients. Yes, we do lose some patients to follow up, and like some that have been from his village who, are fishermen. But at least, let's say with the fishermen, we got the information and the medicine to them, and then they know what the medicine is now, and then they have the ability to procure it elsewhere, if they need to.
Yeah. And that other question was just, is that the same bi-yearly dose?
It is the same by yearly dose. It's just the only thing that changes is based on your weight. So it's 40 milligrams per kilogram. And the pills come in big 600 milligram tablets around the world. That's wherever you buy them, that's what they look like. And so really the only thing that may change is what your weight is. That's all.
Um, it's amazing to think about how much medicine it takes to basically cure this disease.
Yeah, the good news about it is it's very cheap. Not if you buy it in the US, but if you buy it where you are. Like in other words, like if you bought the medicine in Uganda, it is very, very inexpensive. So that's a plus on the plus side.
Um, and then the other question is very important to ask the patient recent travel to different locations like the Caribbean, Africa, or South America.
Yeah.
Um,
I mean, for sure, you want to ask people, again, they're like, what, how somebody's going to present to you here. It's going to be really different than like the extreme I was showing you that we see in our clinic. But, people would present with, apart from the 10% of people that are going to present with Katayama fever, which is, which is basically recent exposure to the water, fever, itchy rash, 90% of people are going to present with fatigue, undulating fevers, diarrhea. And, when I say fatigue, like really, really, you have to think about like, can I get out of bed this morning? So it's pretty profound. Um, and they may be anemic as well. So, there are different factors that you're going to see. And that in combination with like, have you been, kayaking on the Zambezi or whatever it may be is going to, you know, um, that will help point you to your diagnosis.
yeah. I'll make sure to keep that question in my back pocket.
Yes, very
Have you
important.
been have you been
Don't forget
kayaking on
about
the
that.
Zambezi? um, Anybody else have any more questions? Well, I want to say thank you so much. It's
You're
just really
welcome.
interesting to hear about things from places that we don't, you kind of puts context to, for at least for me as a medical student, context behind question bank questions that we get, or, standardized sort of things that we know we need to learn. But it's really
Yes.
amazing to see them in context and with people. And, you know,
Yeah,
that's
it
a
makes
different
it
kind of
real.
learning.
It makes it real. I will also say to anyone who's listening that, because I'm not sure exactly who this whole audience is, but I know they're all medical. We do take volunteers and we do also work with medical students, residents, and anyone who wants to come work with us. So if you're interested, go to our website, softpowerhealth.org, and send me an email. And, we can usually make that happen. So, and then you'll get to see lots of things like schistosomiasis and malaria and severe malnutrition and all kinds of good stuff.
Awesome. Yeah. I will, I can try and pop that soft, you said soft, power
Softpowerhealth.org.
health.org. All right. I'm putting that in the chat, um, so that people can have that if they want it. And I
Sure.
will stop recording now for,